Good evening, everyone. Welcome back to our Life in Motion monthly webinar series. I'm Caitlin, and tonight we have with us Dr. Weaver. Dr. Weaver has devoted most of his career to working in the Memphis area. He has held roles such as Assistant Professor of Neurosurgery, the Neuroline Service Director for Radiation, Oncology, and Stereotactic Spinal Radiosurgery here in Memphis, and he has served as the team neurosurgeon for a number of Memphis-based professional and collegiate sports teams. Dr. Weaver received his medical degree from St. Louis University School of Medicine, completed his residency through the University of Tennessee Health Science Center, and that was followed by a neuro-oncology fellowship with MD Anderson Cancer Center through the University of Texas. Dr. Weaver specializes in spine care from conservative treatments and minimally invasive techniques to spine oncology and complex reconstructive surgeries. This evening, Dr. Weaver will be debunking common myths about spine surgery. Let's see how many you believe to be true. For each myth, feel free to ask questions. Just drop them in the comments, and Dr. Weaver and I will review them. If you're watching on Facebook, YouTube, or LinkedIn, please post a new comment rather than replying to someone else's. We aren't able to see those replies during the webinar. Thank you for joining us tonight. I'll just kind of let you kick it off.
Thanks, Caitlin. First of all, thank you everybody for joining us tonight. It's a privilege to talk to you. And when I was thinking about topics, this really came to mind. I get several similar questions throughout a day of clinic. And I've kind of put those questions into my memory bank and patients tend to ask the same things over and over. Mm-hmm. And so I thought it'd just be a good talking points. And so we'll talk about 8 myths that I commonly hear, and hopefully we can stir up some discussion. And some people have already been submitting questions, which is great. I'd encourage people to submit anything that's on their mind. If it's really specific to patient care or a specific patient need, we might answer that offline. But I do encourage some general discussion questions, and I can really delve into these topics a little bit, and hopefully, even though we're somewhat miles apart, we can have kind of a back and forth conversation. So please submit your questions, and we'll do our best to answer them. So let's go to the first slide there. Myth number 1. And myth number 1 and 2 kind of go together. So you may wonder why I'm starting out with this one, but just bear with me. So one thing I hear a lot of, and it might be because another physician told a patient this, or they've read something online, but I hear patients that say, I have to have surgery because I was told unless I get surgery, I'm going to end up paralyzed. And by and large, 99% of the time, that is a definite myth. And so some of that boils down to understanding the anatomy of the spinal cord. And I've got some models here, but when we talk about paralysis, generally we're talking about injury to the spinal cord itself. What a lot of people don't realize is that the spinal cord actually ends almost before we get into the entire lumbar spine. So when it comes to back pain, now you could have compression on a nerve root, which is different than the spinal cord, but when it comes to back, I mean, it'd be an extremely rare circumstance for somebody to end up paralyzed from a pathology in the lumbar spine. When it comes to cervical spine, it's also very rare. But there are some warning signs, and we can talk a little bit about that. But even where there's high-grade cord compression that's developed over many years or even many months, it's very rare for somebody to be at risk for acutely becoming paralyzed if we don't rush them off to the operating room.
So I'll ask kind of a question following up with that. Sometimes people confuse going to the emergency room versus coming to Ortho South. So what are some warning signs that should prompt someone to seek urgent care versus coming to Ortho South?
Yeah, so if somebody has the acute onset of weakness, and when I say acute, we're talking within a day or two of weakness of any limb or both limbs, bowel and bladder incontinence, those are emergencies. Now, those are very rare. Now, I see a lot of patients, as does all of my partners, that have developed chronic weakness over several months, years. Obviously, that's not an emergency, but the very immediate onset of weakness in a limb, a hand, bowel and bladder incontinence, those are the warning signs. And that's when we sometimes, depending on what the diagnosis is, everything's predicated on getting the right diagnosis, but we will often intervene very, very quickly.
Gotcha. All right. Let's see. Let's go ahead and go to the second myth.
So these go hand in hand. Spine surgery is dangerous. So that's the other side. I have the patients on one end of the extreme that say, I've got to have surgery today, which is generally not the case. But then there are other patients that say, man, spine surgery is just way too dangerous. I'm not a candidate. And there are risks. I'm not saying that there aren't. We'll talk a little bit about that. But in general, spine surgery has become very, very safe. Certainly over the span of my career, I've seen advancements in imaging technology. We do a lot of minimally invasive surgery, which minimizes risk for infection, risk even when there's, God forbid, a complication like a spinal fluid leak. Because we're doing it minimally invasive, that risk is much mitigated. Advancements in imaging, which I just mentioned. Why don't you show the next slide? Because I put an example there. So this is one of the things I'm kind of excited to talk about. This is our 3D MRI capabilities now, and we're rolling this out to our patient population where it allows us, these are still images, but I can show patients on our computer and rotate that 3D model 360 degrees upside down and show them their specific pathology, because I think this is really advantageous. It's hard for patients to get a sense of, when I show an MRI and I'm used to looking at two-dimensional views and the side view and the axial view as if the spine is turned up like that, but it's very hard for patients to conceptualize. So I'm kind of excited to be able to show them the specific pathology where the nerve is being compressed, where the spinal cord is being compressed, and then be able to take that on to the surgical side and say, this is how we go about alleviating that compression on the nerve. So really,
just to clarify, this is like a patient you've seen.
That is an actual patient. And so on this example, you can see the degeneration of the disc. The disc have lost their height. This patient doesn't have a lot of nerve compression that I can show you. But yes, that is a real patient. So getting back to the danger of spine surgery, all that to say, we've had a lot of advancements and things that make it quite a bit safer than what it maybe was 25 years ago.
What are some common risks?
So common risk, I tell people the same things every time we book a case, whether it's the smallest or the biggest spine fusion you can ever imagine. There's risk of stroke, there's risk of death. Those risks are far less than 1%. And with modern day preoperative clearance and our anesthesia techniques and the fact that we're doing a lot of these cases outpatient and not going into the hospital setting where there's known increased risk of infection, we've really been able to minimize those complications. And then to answer your question further, anytime we're operating around the spine and the nerves, there's risk of nerve injury or nerve damage. That risk is also far less than 1%. The infection risk on minimally invasive techniques, which I've got some examples of what minimally invasive means, so we'll talk about that a little bit. But on minimally invasive technique, the risk of infection is almost zero.
Wow. So Miss Carolyn actually asked a question about outcomes. Why are outcomes of back surgery poor for elderly patients?
So we don't really have an age limit to doing a surgery. Every patient is unique, and we take that on an individual basis. I've seen 60-year-olds that look very unhealthy, and on the corollary, 80, 90-year-olds that are very healthy, very active. And so age is just a number when it comes to that. And so everybody's individualized. We go through the steps of preoperative clearance, extensive medical workup, and barring anything that prohibits surgery, if somebody's generally active and mobile, they should do well with an elective spine surgery, regardless of their age.
Gotcha. Alrighty, ready for myth 3?
I'm ready.
All right, I'll announce this one and you can debunk it.
Okay.
Myth number 3 is I need a fusion for my disc problem.
So we see this from time to time. Fortunately, it's not very common, but I'll have patients that present and have been told that they have to have a fusion. And neurosurgeons and orthopedic spine surgeons have a thought process of what is the symptoms? Is it nerve root compression? And if there's, barring any instability or structural instability in the spine, which I'll show you what that means a little bit later, our goal is to alleviate that nerve compression and fix leg pain, arm pain, hopefully without requiring a fusion. However, there are some cases that we need to do those fusions. So why don't you go to my next slide there, and I'll show you an example. So this is a patient that was actually, he came into my office after 2 weeks of being kind of ignored. He had been into the emergency room twice, and nobody ever got an MRI, and he has a very large herniated disc at the second to the last segment there. I don't have the ability to point with a pointer, but that arrow is pointing directly at a massive disc herniation. And so I'm happy to tell the story that we were able to get an MRI on him within a day and get him booked for surgery because he was so miserable within about 3 days. And so that's a big herniated disc. None of my partners, nobody that I really even know in the whole Memphis area would do this, but I do know that there are people out there that would say that's such a big disc. We're gonna have to take so much bone. We're gonna have to do a fusion. That patient does not need a fusion. That's something we can handle with a minimally invasive microdiscectomy. It's about a 30 or 45-minute outpatient procedure. Comes in, has it done. 2 hours after surgery, he's walking out with, in his case, not everybody is like this, but in his case, complete resolution of his leg pain. Very happy.
Wow.
So why don't you go to the next slide there. So this is how we do a minimally invasive microdiscectomy. This is bread and butter neurosurgery, a very common operation, like I said, in and out, outpatient. That's him placed with his stomach down. That's his low back, going very close to midline. And what you'll see here is on the left side of the screen is a dilator. And so I'm dilating through the muscle tissue. I'm not having to make a big open incision. In fact, that incision is only about 1.5 inches in length. You can go to the next slide. And so you're seeing the sequential dilation there with the fluoroscopic image that I'm looking at in the operating room to make sure I'm right on target. Like, it's very precise. And then the next slide. And so once I get that dilation done, that's a tubular retractor that was actually invented here in Memphis. We get the microscope in, so that's myself and Melanie, my nurse practitioner, working in conjunction with each other to go down and remove the bone to get access to where that disc herniation is. Next slide. And ultimately, we pull out this fragmented disc, and in this case, it came out kind of piecemeal. Sometimes they come out in one big piece, but that's what it looks like. I tell people it looks kind of like lumps of crab meat. Uh, and
Very appetizing.
yeah, that was a big one. And like I said, that nerve root is now nice and happy, and he walks out of our surgery center an hour or two later. So
That's incredible.
next slide. And that's the size of the incision. I put a little ruler there so you could see it's about 2 centimeters, maybe a little bit more in length.
So while we're on this, Mr. Jim asked, what back surgeries can you do with regional anesthesia?
Yeah, so that's a great question. That's a hot topic right now. Doing spinal epidurals and awake microdiscectomies and even awake fusions. And I've got an example, not of doing it awake, but I'm going to show you what an outpatient fusion operation looks like, which has really become more mainstay in the last 10 to 15 years. I'm kind of proud to say that myself and a group of other partners kind of pushed that along here in the Memphis community and started doing outpatient fusions. But there are people across the country now that are doing awake lumbar fusions. Now, that to me is kind of pushing it a little bit because those surgeries, they last about an hour and a half to 2 hours. I think it's probably better for the patient to go to sleep. And nowadays with modern anesthesia and, like I mentioned before, preoperative clearance and the safety of anesthesia, I think it's actually a lot safer for somebody to be asleep. But it is being done. And awake microdiscectomies that last 30 to 45 minutes, you could probably make a case for that.
I don't know if I would want to be awake during a fusion.
I personally wouldn't.
All right, let's go on to the next myth, myth number 4. Recovery from spine surgery can take months.
Okay, so this one it comes with some caveats. There are big surgeries that we do that can take months. If we do a big scoliosis deformity correction surgery where the incision is a couple feet in length and we split all that muscle and realign the spine, that's a life-altering surgery that will take months to recover. But by and large, the bread and butter surgery, at least that I do in my practice, and a lot of my partners do, does not take months. Most people, for like the case that I just showed, that patient really, I tell them to take it easy for about 3 weeks because we want to minimize the risk of the incision breaking open or reherniating a disc in that acute period. But they're kind of back in the swing of things pretty quickly. The same is true with neck surgeries. I happen to do a lot of anterior neck operations, and I tell people that, you know, you're probably going to be back in the swing of things at a week or two.
Very nice. All right, I actually have a question for this one. Do all patients need physical therapy after spine surgery?
So no. In fact, most people don't need physical therapy, but I say that we really focus on the individual, and that's the beauty of being at a place like Ortho South where we have a spine institute and we can offer all the comprehensive aspects of care. And so, yeah, there's patients that definitely need rehab, especially when their preoperative neurologic deficit is present. We've got to get them better. We employ physical therapy both on the front end and the back end from surgery very often. But by and large, most people end up doing well and can recover at home on their own. I encourage a lot of walking, and we talk about activities that we can do. But yeah, if they need therapy, we've got that, and we employ it when it's needed.
Very good. All right, I'll let you take this one.
So, in line with the physical therapy, this is what I tell our patients after a lumbar microdiscectomy. I kind of think of it in 3 phases. So first phase is we just really want you to recover from the surgery. We're not going to do any bending, twisting, nothing greater than 20 pounds. I don't really want physical therapy during that time. It's just a time to recuperate and get better. You can hit the button there. And then we go on to phase 2, which I think of in the 3 to 12 week phase. And so after a lumbar microdisc, like the case I just showed, we just increase our daily routine as tolerated to get back to work, especially if it's a desk job. No problem in going back to work at this point. We'll begin physical therapy if necessary, but I want to avoid exercises that stress the low back. It's common sense stuff. We're not going to do heavy squats, deadlifts, axially load the spine, so no overhead stuff, no bending. And then phase 3 is more of the longer term phase. So anybody that's had back surgery for the rest of their life, not to have to live their life in a bubble, but it's good to just kind of keep some things in mind. So even though we're back to full activity, I always caution against doing like really strenuous lifting, like Olympic weights, Olympic lifting. And then we might employ some maintenance physical therapy and just really work on some general strengthening, core strengthening in patients that I feel like need it.
Awesome. All right, let's see. Let's go on to the next slide. Myth number 5.
I won't be able to get back to doing the things I love. So this is everybody's concern. It's my concern if I have to have surgery. By and large, it's a myth. Even with a lumbar fusion or multi-level lumbar fusion, multi-level cervical fusion, kind of the most common things that are on the more aggressive side, it's not prohibitive. I tell people they can get back to playing golf, pickleball, all those common sports. That's when we start to talk about employing physical therapy and other modalities and really getting people back to those activities with specific physical therapy exercises. We've got a huge physical therapy department, so that really affords us the ability to really hone in on what people want to accomplish and focus on their goals after surgery.
So is there any like a most common restriction that you see after surgery? I know there's several different levels of surgery, but the ones that people are most scared of?
The most common one I hear, just because it's a common activity, is can I play golf again?
Yeah.
The other common ones I hear, can I get back to gardening? Gardening, golf, yeah, totally, but we want to get you through those phases that we talked about. I've got another phase kind of laid out for our fusion, which is coming up here in just a second. One thing that just pops into my mind is yoga. That's one that comes up quite a bit. In somebody that's had a fusion, I generally discourage yoga because of the very funny twisting and bending postures that you have to get into.
Yeah.
So that's one thing I tell my patients. I'd really like you to think about maybe doing something else. Let's modify. Let's try to stay away from those funny postures. If you can do the yoga, but let's not do I can't remember what. let's not twist. Heavy runners, I'll often tell them, well, maybe it's best that you do stationary bike, or swimming is an excellent activity. So there are times when I will counsel people to modify things a little bit.
Awesome. All right, myth number 6.
All surgeries require hospital stays. This is definitely a myth. In fact, about 80% of my practice and some of my partners is now all outpatient in a surgery center, which is wonderful for myself, my patients, not to have to go into the hospital environment. Less risk, less complications, obviously much shorter stay, like getting people up and moving after surgery within an hour or two makes a huge difference in post-operative pain, and just gets them on the recovery track much sooner. And so it kind of brings me into the next thing I wanted to talk about. We're even doing bigger surgeries in an outpatient setting. And so this is an example of what we've kind of alluded to earlier of a lumbar fusion, and it's called a minimally invasive TLIF, which stands for transforaminal lumbar interbody fusion. Just like the discectomy I showed, we do this through a tubular retractor, which allows us to make very small incisions You can go to the next slide. And for a case like this, it looks like it's just another herniated disc there. However, what you'll see there, and I've tried to highlight that on the middle and the slide on the right, that's called a spondylolisthesis. And so what's happened is that vertebral body has slid forward on the one below it, and that's an unstable spine. And so that in and of itself, if you imagine that vertebral body sliding forward, it's going to compress against that nerve here and cause not only back pain, but pretty significant leg pain. And that patient cannot be done with just a standard discectomy. That does indeed need a fusion to eliminate that instability. You can go to the next slide. And so that's that's the initial stages of the surgery. So we're doing this through 2 small incisions on either side of the back. Each incision is probably about 2 inches in length. And it allows me to drop some rod or some screws over those K-wires that I place under X-ray guidance, and then drop a rod through those small incisions, kind of come in at an oblique angle and place that rod through the screw heads under X-ray visualization. I can't directly see that because the incisions are so small. And then working through the tube, we do the mainstay of the operation, which is getting the nerves decompressed. So that's a lot of bone removal with a drill, working with instruments delicately around the nerves, and then you can go to the next slide. And placing a graft in the disc space that also allows us to really open that disc space and indirectly decompress that nerve root tube by creating that space. And you can go to the next slide. And so that's the expandable cage going in, and so that I'll crank that cage open, and that pulls those vertebral bodies back into alignment too, in combination with the screws. And you can go to the next slide. And so there's the cage that's been deployed and creating that nice disc space height that we like to see. You can see the difference between the left and the right slide there with the cage in place.
Now, just for those who aren't familiar with cage, that is the middle of the left picture.
Yeah, thanks for asking. That's that little teardrop spacer in the disc space between the vertebral bodies. And ultimately what's going to happen is the patient's own bone is going to grow across that spacer. It's hollow on the inside, and so that's the fusion. That's what we want to take place, is that bone to knit across that spacer.
Gotcha.
And so that's the end product. That's the 2 small incisions. And again, this is outpatient. It takes about an hour and a half, sometimes 2 hours, and patients get up and walk, and that's the key. When we do this in the hospital is not so great about coming around and really encouraging people to get up immediately. In our surgery center, we kind of fight through some of that post-operative discomfort. Not that it's horrible, but we get people up, get them moving, and that makes a huge difference in their first couple of days after surgery.
Now, is there anything that really separates like criteria that separates somebody from having inpatient versus outpatient surgery center?
Sure, there's lots of things we look at preoperatively, and preoperative clearance is a huge one. But by and large, we're going to try to do most everything in our surgery center if we know that it's safe to do. And sometimes our anesthesiologists say, that's not safe to do. No problem, we'll go to the hospital.
Gotcha. All right.
That's another example that's a little bit more clear, spondylolisthesis, and then the end product where we've reduced that slip of that bone on the adjacent segment. We've reduced that back into more normal alignment. That's why we do the fusion like that.
Yeah.
Yeah. So expectations after fusion, to kind of get back to, does everybody need physical therapy? Here we might employ physical therapy a little bit more aggressively, just because it's a bigger surgery and people need a little bit more recuperation time. But a lot of these lumbar fusions don't even need physical therapy. We'll have them walk on their own. So phase 1, I don't want much of anything other than recuperation, just like the lumbar disc, and that lasts about 2 weeks. After about 2 weeks, we increase daily activity. We'll start our therapy at that time, but unlike the lumbar disc, we don't want any bending or twisting right now. We really want that fusion construct to maximize its potential to fuse without any problems. And so then we go to phase 3, 6 weeks to about 6 months. We're getting back into our normal activity, work, no problem. But still, I tell people, I don't want you doing any repetitive bending or twisting. I really want to maximize your chance to fuse. And that fusion takes about 6 to 8 months to really get solid and robust. And so phase 4 is that 6 months and beyond. Just people that have had back surgery, certainly a fusion, they've always got to keep that a little bit in the back of their mind. We don't want to do really strenuous things from now on. So. Myth 7, I'm hurting and surgery is my only option. Well, I'd be remiss if I didn't talk about the conservative approach at the Ortho South Spine Institute, because we want to use surgery as our last option. That's what I tell people almost all the time. And so my first visit with people, it's, getting to take that history, doing an exam, but I'm kind of thinking, okay, what can we do to employ non-operative strategies if we can? Now, if there's a neurologic deficit, like things that we talked about earlier, acute weakness, like oftentimes we need to do a surgery. We got to get those neural elements decompressed or whatever. But by and large, we're going to try all the conservative things first, and that requires a little bit of patience on the patient's behalf. So we might want to try some of these things like medications, steroids, non-steroidal anti-inflammatories, physical therapy. A big favorite of mine is aquatic therapy, because that works great, especially for low back pain, where we can get somebody in a weightless environment so they're not bearing that weight, but they can get all the benefits of the core strengthening and the stretching and the flexibility. Chiropractic care is another one. I see a lot of patients in conjunction with chiropractors around the Memphis area, and they do great work. And then we employ injections. And so I think of the injections as kind of the second arm of the conservative treatment strategies. So those might include epidural steroids, selective nerve root blocks, facet joint injections. And then I threw neuromodulation on here. This is something that comes kind of more after patients have failed multiple surgeries, which unfortunately can happen. And we talk about placing spinal cord stimulators. So,
what is the role of the stimulator?
So a spinal cord stimulator works by, it's 2 electrodes that go up into the vertebral column and stimulate on top of the dura, provide a low voltage electrical current that kind of masks the pain sensation coming up from the lower limbs, the low back. We can do paddle leads up in the cervical spine for neck or arm thing, but by and large, it's mostly for low back and leg pain.
Gotcha. Mr. Jim said, does prednisone and muscle relaxers, are they helpful?
Oh, totally. We use that all the time. That's oftentimes kind of our first line treatment for somebody that comes in with just an acute onset of severe leg pain or severe arm pain, and we're going to then go on to get a workup done, whether it be MRI or whatever. I give people steroid packs and muscle relaxers every day. Awesome. The problem is that it's temporary. So we don't want to keep people on long-term steroids, obviously, and so we'll do that to get them through the workup, but hopefully we can nail down the diagnosis and get a more definitive treatment.
All right, let's see. Let me throw in one more question. So for patients that have spinal stenosis, I know that's a wide range of different levels of that. If someone is older with a lot of arthritis and spinal stenosis, is this the process that you would follow?
What process?
Or like
the conservative?
Conservative first.
Yeah, I mean, everybody's a little bit different, individualized. If I see a patient that's got severe spinal stenosis in the cervical spine, And just to kind of give you an example of the extreme this could be, I mean, some people are so severely stenotic that they're having trouble using their hands, walking, because the cord compression is so severe. Conservative management's only going to take us so far in that case. And that patient needs surgery. That cord needs to be decompressed. And so those patients are some of my happiest patients. Once we get that spinal cord decompressed, things start to work a lot better. They start to walk better. However, if it's general pain without a neurologic deficit, absolutely we'll try all the conservative things first. But I tell people that that's just the first step, because we're going to see you back a couple weeks after an injection. We'll see how that worked. If it didn't work, we're going to go on to the next thing, and we'll gradually get more aggressive as we cross things off that didn't work, and hopefully they worked.
Awesome. All right, let's see. Let's go ahead and pull back up the slides real quick.
I see a question here. I'll just answer it real quick. Do I always use staples? I only use staples on lumbar fusions. When we do a neck surgery, we don't use staples. When we do the lumbar disc, I use a Dermabond glue, so no. Yeah.
Not always. Do you have like a percentage, or does it just depend on?
Probably about 15% of the cases we use staple.
All right, myth number 8.
It's difficult to see a spine surgeon, and I can see why people might feel that way. Like, do they feel like they have to be referred from their doctor? Or they just didn't know that it's easy to access us. And that's something that Ortho South in particular really prides itself on, its ease of access. So if you don't mind, Caitlin, I was gonna let you kind of tackle this one and maybe walk through how easy it is, and I've been a customer, to book online. And then for people that maybe don't like the online, we got a telephone number they can call and get scheduled. And not only for spine, but I'll put a little plug in for the orthopedic partners as well, whether it's hip, shoulder issue. There's 30 plus providers. You can be seen the same day at one of, well, how many locations now? 8 locations across the whole Memphis area. So it truly is that easy, and something that the Ortho South group as a whole really kind of prides itself in and tries to work on this. And so it should not be hard at all to get in to see a spine surgeon.
Correct. So, of course, like the phone number is a route to go. But if you have your smartphone or a computer, you can go to orthosouth.org, or simply just Google Ortho South and go to our website. And then once you're on our website, this is our homepage of our website. Up at the top right corner, it says Book Online. Now, if you're on a mobile device, there will be the hamburger symbol, we call it, with the 3 lines. Click on that and you'll have the same button. So Book Online, once you click on that, super easy. It'll pull up this first page that's on the left, and you say, are you an existing patient or a new patient? If you're unsure, you can click either one. It's pretty smart to find you. And then you make sure that you're not a robot, select that. Next, you'll put in some basic information at the top. You'll put in the reason for your visit. When you put that in, it'll also allow you to select a provider. So if you have a provider in mind, you can put that information in, and then fill in your basic information, and it'll load, pull up all the appointments. It does it by zip code to the closest clinic to you, as well as the most available time. And then there's filters that you can select, like if you only need an afternoon appointment, you can filter that out. After doing that, selecting your appointment, you'll put in a little bit of more information just for us to register you, and then you'll be set.
It's almost as easy as ordering a pizza.
Yes, yes. All right.
Great.
All right, so we're going to open it up to some questions. If you have any additional questions, feel free to add those to the comments. Let's see.
There's one, the TOPS technique for a grade 1 spondy. Yeah, that's a newer motion preservation type surgery. I've looked into it a little bit. I do think there is a time and place for that, and for grade 1 is a good example of where it is appropriate. If you start to get into the higher grade, there's just so much instability there that it's in my opinion, it's kind of a doomed to a failure. But for a grade 1 spondyes is certainly a very, very good option. Problem is, it requires a little bit more of an opening, so a little bit more muscle splitting. But yes, it's a good surgery.
All right. Let's see. Now, some of them may be a little specific for you to answer directly. Do you see any that you want to answer?
Yeah, Scott asked if I have a neighboring fusion of 2 discs. Can the hardware be removed when doing a new disc replacement? So disc replacement is I think he might be talking about the cervical spine. If it's lumbar spine, the answer is no, because that would require, the disc replacement's done from an anterior approach, and to get the hardware out, you'd have to come back posteriorly. But for cervical spine, which I think is what he's asking, yeah. And in fact, that's probably what we would do, is get all that hardware out, assuming you're fused. We do that all the time on ACDF. And
yeah, he did say lumbar.
Oh, lumbar. Well, lumbar's a lot trickier, so that's going to require two separate procedures, and you may not have to have that hardware removed and just do the disc replacement if that's something he's interested in.
Sounds like someone can go on to our website or call us and book an appointment.
Absolutely.
With you. And then let's see, Miss Carolyn said, what is the first surgical option for spinal stenosis?
Oh, that one I can't answer. Yeah. That's all predicated on how many levels, where's the compression, is it posteriorly, anteriorly? I mean,
it's patient specific.
Is it lumbar, is it cervical again?
Yes.
So but again, that's what we pride ourselves on, is really tailoring. There's no cookbook strategies here. This is all tailored to the individual patient. So.
Yeah. One of the myths that I've heard that I actually recently found out is not true is like your mattress matters, what mattress you get.
That's so patient specific.
Yeah.
I wish I could tell somebody this is, and I could sell them, this is the mattress you need, but it's not the case. Some people do great on a more firm mattress, and then the other extreme, like soft mattress. It's totally, and the same thing with pillows.
Awesome. All right. Well, thank you everybody for joining us. Hopefully you learned a bunch about myths that you may have thought are true and they are not true. Dr. Weaver, is there anything you want to add as we close? No, thank you all for joining us tonight. I hope it's been informational, and reach out to us if we can answer any more questions. We'll try to respond to everybody who submitted a question tonight. Awesome. Thank you guys so much. Thank you.